Going live in 30 seconds. Request everyone to mute their microphones. Good evening, everyone. Welcome to today's masterclass, brought to you by the IASO Academics. Today is chapter 58 in this series of masterclasses, which have been brought to you by IASO and which are there on YouTube. The previous 51s are there on YouTube for you to go and browse as well. It's my pleasure to invite Dr. T.S. Rao, the Academic Council Convener, as well as the Vice President IASO, to deliver the welcome address today on behalf of our IASO President, immediate past President, Dr. P.K. Das, who is unwell and could not join today because even right now he's not feeling too well. So, yes, Rao, sir.
No, it's a privilege to be introducing the three gentlemen. What's common between them is they're all three are fierce academicians. All of them are simple, honest, and truly teaching and training oriented individuals. So that's something that unites them. And that is the reason why they are here today. Kalarasan Raja, we've known him for close to 2 decades now. He every slide he brings in, every word he talks, there is loads of wisdom. He's an additional professor at the prestigious Jawaharlal Nehru Institute of Postgraduate Education and Research, Pondicherry. Because he's an associate professor in the once again a prestigious institute, the Gujarat Cancer Research Institute. Somebody who all of us would want to listen to today. Pawan Sabur is someone I've seen him grow, someone who is holding the torch for Kidwai Memorial Institute of Oncology as an associate professor, somebody who's really loved by his students and his seniors alike. Welcome, gentlemen. We know that this will be one of the best sessions. The examinees today are Milan Joshi, resident from Raman Manohar Institute of Medical Sciences, Delhi, and then Akshar Arvind, who is a resident in Madurai Medical College. Best of luck, Milan and Akshar.
Thank you, sir.
Thank you, sir.
I request Pawan to take over and run the show. Thank you.
Yeah. So
Thank you so much.
I request Dr. Pawan to load up his slides. Meanwhile, he does that. Just a few instructions to our moderator, Dr. Pawan. We request you to address both examinees by their name when the question is being asked to them, so that there's no confusion and they know who's supposed to answer. That applies to all the three examiners. And especially for the moderator, you have to ensure that both these examinees get equal opportunities to answer and participate. To our examiners, please, you have to give the expected answers to the questions that remain unanswered or have been incorrectly answered by the students. This differs from how an actual exam goes, but that is there for the interest of the other live participants as well as participants who are viewing this on YouTube later. For the examinees, if you don't know something, just mention it so that they can move on to the other examinee or move on to the next question. This will save us some time. For the other participants in the on live who are on Zoom here, or if you're on YouTube, please know that whatever questions you put on the chat box will be collected by me and will be asked to the all the three examiners at the end of the session today in the Q&A segment, which follows the expert talk. So if you have some doubt that you always wanted to ask, or if there's some doubt you have during the discussion of this mock exam, please put in your query, and we'll make sure that those get answered to the best of the examiner's knowledge. With that, we hand over to Dr. Pawan to commence the mock exam. Thank you.
Thank you, Srijan. I'll just end up sharing my slides. Well, my slides are visible?
Yes, sir.
Yeah. Good evening. At the outset, I would like to thank the IASO organization for the opportunity. And I send out my warm greetings to Dr. Subramanieshwar Rao sir and Dr. Srijan Shukla, and deeply appreciate their incessant efforts for driving this academic masterclass. And that's how the module has been structured in such a way that there are certain topics must know, you should know, and nice to know. And it's good to hear from Dr. Kalai and Dr. Vikas about certain aspects of a periampullary tumor. And we'll take you through and engage you in discussions in depth of anatomy, physio, patho, and radiology, and finally fall onto the medical and surgical management. I just want to hear from Dr. Kalai and Dr. Vikas, how do we keep it going? Do we start with history, pause at history, and then engage them in a discussion, or should I completely finish the presentation and then we come back in bits and pieces?
I think it would be better that once we finish the history, then we can ask them some questions about the history part, and then we move to the next section.
Perfect. Right. So that's going to be the flow. And the two case capsules which is being summarized, one is for an resectable pancreatic malignancy, and the other one is an borderline resectable pancreatic cancer. So the case capsule 1 goes like this. It's a 53-year-old lady, homemaker, ECOG 2, no comorbidities, presented with chief complaints of yellowish discoloration of eyes of 1 month duration, passing of clay-colored stools and high-colored urine of 2 weeks duration, with symptoms of pruritus and intermittent fever of a week duration. On elaborating history, there was a waxing and waning pattern of jaundice, not a painful jaundice, but she complains of a vague upper abdominal discomfort associated with loss of weight and a loss of appetite. Loss of weight seems to be significant, that is 3 to 4 kgs over past 2 months. There's no history of abdominal swelling, distension, altered bowel habits, no hematemesis, melena, bone pain, or seizures. And when you look at her past history, there's no past history of blood transfusions, jaundice, biliary colic, or any upper abdominal surgery. Family history is by and large not contributory. Yeah, can we go on to the Dr. Kalai Rasan and Dr. Vikas? Anything you want to add in?
Yeah,
that should be fine.
Probably, maybe I'll ask one of the candidate. Maybe Dr. Milan can answer this.
Yes.
So they mentioned waxing and waning pattern of jaundice. So how will you elicit that history from the patient?
Sir, to elicit this history, we'll be asking the patient whether in the duration of their jaundice, there was a period where they noticed there was a decrease in the intensity of the jaundice, or the color of the urine, if there was any difference. And here, basically, sir, the jaundice is not going to completely go away. It will only decrease in intensity, and it will come back to the same intensity as it was before.
No, I think, are you sure that, because see, once the patient develops jaundice, so how they will notice, and do you think that intensity, so you must have seen many times the patients are stented, so how often you see the intensity of jaundice? So basically what I'm asking is, what specific question you will ask the patient? You ask the color of the eyes or color of the urine? What do you specifically ask to know that there is some reduction in the jaundice?
So, history of melena.
If you specifically mentioned waxing waning means the bilirubin does not come back to normal. It just reduces and then increase. So you had some in the previous slide has some points. So which of those will help you to clearly elicit this history?
Clay colored stools.
Yeah, I think that's I think the Akshara answer, right? Okay. So I mean, it's because the stool, it changes every day. So from clay color stool, and in between the patient passes normal colored stool. Okay, that means on those days there is some relief in the jaundice. Okay, relief in the obstruction.
Yes.
So that is one thing which help you to elicit compared to other things, because as you know, the eye color does not come down normally immediately,
Yes,
and
sir.
urine the patient may not observe that well.
Yes, sir.
So along with that, Dr. Joshi, is there anything else that you would notice in the stools when you are talking about a waxing and waning pattern?
Yes, sir. So there could be melena, sir. History of melena could be present. There is passing dark tarry stools which sticks to the pan, which could be suggestive of a periampullary tumor sloughing off, and which could have relieved the jaundice, which caused the waxing and waning in the jaundice.
Dr. Joshi, what do you mean by an ampullary tumor and what is a periampullary tumor?
So, ampullary tumor is a subtype of a periampullary tumor. Periampullary tumor basically involves any tumor that lies within 2 centimeters area around the ampulla in the second part of duodenum. And ampullary tumor is a subtype of periampullary tumors.
So what is so by definition, what is an ampullary tumor and what do you mean by periampullary tumors? So what all does periampullary tumors encompass?
Yes, sir. So periampullary tumor basically have 4 subtypes. First is tumor of the head of pancreas. Then there is ampullary tumor, which is involvement of the sphincter of area around the sphincter of OD and the ampulla of Vater. Then
So
there
that's
is
the only definition for an ampullary tumor? Ampullary tumor is only the tumor that involves the ampulla, or is it something else?
Sir, ampulla and the surrounding duodenal mucosa also, sir.
So the surrounding duodenal mucosa becomes periampullary tumor.
Yes, sir.
So ampulla as well as the intrapancreatic and the intraduodenal part of the pancreatic duct and the intraduodenal part of the biliary duct.
Biliary duct, yes, sir. Yes, sir.
So that is the ampullary tumor.
Yes, sir. Yes.
Okay.
Yeah, just one Dr. Akshay, actually, Dr. Joshi, she answered, you will have melena in between in patients with an ampullary tumor. So, do you always observe melena in a patient with jaundice, or if not, why?
Sir, if there is a mucosal erosion of the GI tract, there may be some bleeding and we may get melena, sir.
No, what I meant is, when there is a GI bleed, in a normal patient, you see melena.
Yes, sir.
A jaundice patient, do you always have the typical appearance of melena, or sometimes?
Sir, it's a silvery colored stool, sir. The pale color and the melena is combined, sir.
So why that happens? Why a normal patient has a melena? Why in jaundice it is the color is that silver paint?
Loss of stercobilin, sir.
Yeah, so that's something you have to remember. Okay, so you may not always, the bleeding does not always manifest melena, because sometimes when the obstruction is near complete, when there's no stercobilin formation happening, so you will not have the typical appearance. Okay.
Yeah. If I can make a comment.
Yes, moderator always.
The moderator is always right.
Milan, if you could take this question, can you describe ECOG2? What does it mean to you?
Yes, sir. So ECOG2 means that the patient has restriction in activity, which is limited to light and like office work, etc. And the patient is up and about for more than 50% of the day. Patient can do self-care activities, and patient is ambulant, sir.
Perfect. Does it have any implication in a hepatobiliary system? ECOG2.
Sir,
would you assess ECOG status in 2 different timeline, or would you stamp the patient ECOG2 always in a hepatopancreaticobiliary system?
Sir, ECOG, we will So one is like in this patient, if the patient has jaundice, one will be prior to doing any intervention, and then another one will be post-intervention, the conditioning of the patient. We'll
Very
take
nice.
ECOG
Yeah.
at 2 different times.
So be mindful when you stamp a patient ECOG status, it should be post biliary diversion, yes, in an obstructive jaundice patient. And what is significant weight loss for you?
So significant weight loss is loss of 10% of body weight in 6 months, or 5% in 1 month, sir.
Okay, I think it's last I looked into, it was 5% over past 6 months. If you could go back and check in. And can you take us through the thought process of when I say my past history, can you corroborate with each finding of mine, and what are your insights on it? When I say it is no history of blood transfusion, jaundice, biliary colic, what am I trying to conclude, or what was your thought process?
Yes, sir. So when we are talking about no history of blood transfusion, basically we are looking into any infective cause for the obstructive jaundice, or infections which are transmitted via blood transfusion, which could be hepatitis B and hepatitis C. Apart from that, it could also be due to hemolysis, which occurs during multiple blood transfusions. For a history of biliary colic, when we're talking about, we are looking for benign causes of obstructive jaundice, which could be a history of choledocholithiasis or a slipped stone into the CBD. And any past history of jaundice, we could be looking into a recurrent or an infective etiology. A patient who has some chronic disease associated with liver, sir, like chronic liver disease, patient could present with jaundice in that scenario.
Perfect.
Yeah, I'd like to ask Dr. Joshi,
Yes, sir.
what do you understand by the performance status of the patient? You said ECOG, fine, agreed. What is the performance status of the patient? We generally talk about PS, the performance status.
Yes, sir. Yes, sir.
Yeah. So, what is the performance status?
So
what criteria would you like to see? Dr. Akshar, the performance status of the patient.
Conditional.
We really like to divide the patient into good PS and poor PS. So, what do you understand by good PS and what is poor PS?
Sir, it is a criteria for conditional borderline resectability, sir. Patients with ECOG less than or equal to 2 are considered resectable. And those
I didn't ask for resectability. I said performance status. So that can be for resectability, that can be for whether you want to subject the patient for palliative or for aggressive chemotherapy regimen. That's totally different. Yes. I'm just asking, what do you understand by a performance status of the patient? And what are the criteria that you look? So a good performance status is ECOG 0 or 1 with an adequate nutritional intake and an adequate biliary drainage. So if these three things are there, so you label the patient as good performance status. Otherwise, it's a poor PS. Fine.
Yeah. May I proceed? Can I present the clinical examination? Yeah. So on general examination, moderately built, poorly nourished lady, febrile at the time of examination, icteric, no palpable supraclavicular lymph nodes. She's got generalized scratch marks, no signs of a liver failure which were evident. And local examination, soft, no palpable mass, no hepatosplenomegaly, no ascites. Systemic examination was by and large nothing contributory. Yeah.
Yeah, Dr. Millen, what could be the possible reason for the generalized scratch marks?
So there is in obstructive jaundice, there is deposition of bile salts in the subdermal layer of the skin, which leads to itching, and the patient incessantly scratches, which leads to scratch marks for the same. Sir.
Could you describe the entire metabolism of bilirubin in an obstructive jaundice patient, which is kind of, you need to know all the pathway of it? Either of one of you, Milan, Dr. Milan or Dr. Yeah.
So bilirubin is produced by breakdown of heme and hemoglobin and myoglobin, sir, by heme oxygenase. First, biliverdin is formed, and then biliverdin is converted to bilirubin, sir. and then this bilirubin is bound to, this is produced in the bone marrow and in the reticuloendothelial system of liver and spleen. From there, it is transported to the bloodstream via albumin. This albumin-bound bilirubin is then taken up by the liver, where by where glucuronation of bilirubin happens, and bilirubin glucuronate is formed.
That's in the hepatocytes.
That's in the hepatocytes.
Right.
This is called conjugated bilirubin. Now it becomes water soluble.
Perfect.
And
post that, what happens once
post
it is
that,
conjugated?
So from the basolateral membrane, the bilirubin is entered from, and now along the canalicular membrane, the bilirubin is excreted, and all the bile duct canalicular join and form the intrahepatic bile ducts, and via the common hepatic duct, because there is an action of sphincter of body, this bilirubin gets all the bile, which includes bile pigments along with bile acids and phospholipids. These get concentrated in the gallbladder. And during feeding, because of the action of vagal innervation and cholecystokinin, gallbladder secretes the bile along with the relaxation of the sphincter of body. And this bile. Yes, sir?
Hepatocytes conjugation, post-conjugated into the enterohepatic circulation. How much of the bile gets into the enterohepatic circulation?
So 99% of the 95 to 99% of the bile is reabsorbed daily, and there is only a very few amount of bile that is actually produced.
Right. And what is the explanation for an high-colored urine in an obstructive jaundice patient?
So the high-colored urine is due to bilirubin, sir. It is due to bile.
Yeah.
Bilirubin, sir. Conjugated bilirubin, which is excreted in the urine, sir, because it's water soluble and will get excreted in urine. Sir.
So it finds a pathway to excrete through the body, and that's the only pathway is the urine.
Yes.
Good. Dr. Kalai, any insights, any comments?
In obstructive, how will you actually differentiate obstructive versus hepatocellular jaundice on the urine?
Sir, it is based on Fauchet test and Hayes test. On the
what
urine.
is absent in a patient with an obstructive jaundice?
In an obstructive jaundice, urobilin will be absent, sir.
So why it is absent?
Sir, because in the colon, in the terminal ileum, because of the bacterial action, the conjugated bilirubin gets reduced, sir, to urobilinogen, stercobilinogen, and mesobilinogen. These are partially gets absorbed into the blood, and it's excreted in the urine, sir. So if bile is not entering the in the bowel, then urobilinogen will not be formed and urobilin will not be formed. So there won't be any urobilin in the urine.
Good. So basically, these are all the components of the bile which reaches the intestine. So the moment there is no bile in the intestine, so of all the components, only urobilin gets absorbed from the intestine and exceeds in the urine. So moment there is no bile in the intestine, so you won't have urobilinogen in the urine, and there is no stercobilin in the feces. That's why you don't have you have the clay-colored stools. Okay. Yeah, it's important. Basically, the one which is, it's always important to understand the full metabolic pathway so that you can easily explain the clinical manifestations.
What are the signs of liver failure, and what is the pathophysiology of a liver failure in an obstructive jaundice patient?
The signs of liver cell failure from head to toe would be alopecia, parotid swelling, spider nevi, palmar erythema, gynecomastia, testicular swelling, and
Atrophy.
Testicular atrophy. Testicular atrophy. Apart from that, patient can have ductine contractures.
Very good. Excellent. Yeah.
So these are the signs of liver cell failure.
And what's the pathophysiology? How do you explain it? secondary to liver failure is secondary to, I mean, signs are secondary to liver failure. Liver failure is secondary to what? So it explains that there's an element of a decompensation or a cirrhosis because of a biliary obstruction. So biliary cirrhosis is also one of a causative factor for your cirrhosis, right?
Yes.
Yeah.
Yes, sir.
Dr. Vikas, any comments?
Yeah, fine. You can go ahead.
Yeah.
So can you summarize all the salient points and arrive at a provisional diagnosis?
So this is a 53-year-old lady with ECOG status 2 presenting with an obstructive jaundice, probably due to a malignant cause, which is suggested by the passage of yellowish with the yellowish discoloration of eyes and passage of clay-colored stool and high-colored urine, with a waxing and waning pattern of jaundice. So my most probable differential at this point would be a malignant etiology, probably a periampullary carcinoma.
Dr. Milan, why do you suspect a malignant etiology? Why it cannot be because of any benign pathologies?
Sir,
What are the points that go in favor of a malignant etiology in your case?
Yes, sir. Sir, one is the short history of presentation of the patient. Patient is presenting with a painless progressive jaundice, and patient gives history of loss of appetite and significant significant loss of weight over the past 2 months. So these are few, and patient's performance status is also sir, not good. So these are few points which tell about a probable malignant etiology in this case, sir.
Dr. Kalai, any comments you would like to add in, any insights?
So you mentioned probably due to periampullary, right?
Yes, sir.
So anything in the examination which supported your diagnosis?
Sir, more than the examination, sir, when the patient presents with the history of waxing and waning of jaundice, we can, it could be more in favor of a periampullary carcinoma, which sloughed off, which caused the waxing and waning of jaundice. So that is why I thought of a periampullary carcinoma in this case, sir.
You're giving more importance to that finding in the history. Okay. Anything that does not support in the examination?
So could I have a look at the examination findings, please?
Okay.
Sir, one point which does not support a malignant etiology could be, sir, that there were no palpable masses in the abdomen on per abdominal examination. Apart from that, sir.
So in a periampullary malignancy, what kind of a palpable mass would you?
Sir, if
have in mind, yeah.
Sir, if it is a periampullary malignancy and the patient will have a distended gallbladder, which can present as a globular distended mass present in the right hypochondrium, which moves with respiration.
So one could be a distended gallbladder.
Yes, sir. So patient can also have a hepatomegaly in cholestatic cases, and patient can have in case of advanced diseases, patient can present with ascites as well, sir.
So if the patient presents with ascites, splenomegaly, what could you think? What could be there associated with the periampullary malignancy?
Sir, if a patient presents with ascites and splenomegaly, in a case of periampullary carcinoma, we can think of a extrahepatic portal vein obstruction, which is leading to portal hypertension in the patient, which is causing the splenomegaly and ascites in this patient.
Fine.
So because you didn't have a palpable gallbladder, so you should have the hilar obstruction also in the differential diagnosis. I agree with your likely diagnosis with based on the history, but since you didn't have, so you should have as a
Yes, sir.
Diagnosis.
Definitely, sir.
I move on to the next slide.
Yeah.
So provisional diagnosis is obstructive jaundice, probably malignant, secondary to periampullary is your thought process.
Yes, sir.
So how do you like to investigate this patient? What is on your checklist?
So first of all, I would like to get a few baseline investigations done for this patient in the biochemical workup done in the form of a hemogram, a liver function test, and the renal function test, and coagulation profile done for this patient, sir.
Dr. Milan, could you eyeball the investigations and let me know how would you optimize each one of it? Each one of them is every parameter is significant, which needs an optimization before we proceed.
Yes, sir.
Can you just take the entire blood investigations onto you and go one after the other?
Yes, sir. So first of all, we are seeing that the patient's hemoglobin is 7, which is suggestive, which could either be due to a chronic etiology or it could be due to the presence of an upper GI bleed in this patient due to sloughing off of the intestinal mucosa or the periampullary region. In this case, the hemoglobin is 7, sir, and the patient's ECOG status is 2. Patient might require blood transfusion for the same prior to starting the patient on any kind of further treatment. Any modality of treatment will require blood transfusion in this case. So next, the patient's total counts are 12,400. Patient is giving a history of intermittent fever, which could be suggestive of cholangitis in this case.
What do you understand by intermittent fever? What is your understanding when we say intermittent fever?
So in the patient of obstructive jaundice presenting with intermittent fever, it is a part of the Charcot's triad, which is suggestive of cholangitis in this case. Patient could be having cholangitis. Sir?
Yeah, go ahead.
Yes, sir. So next, the patient's creatinine at this point is 1.6, which is suggested that usually patient present with obstructive jaundice are dehydrated. So this could be a patient in acute kidney injury due to obstructive jaundice. So the patient will require adequate hydration for the same. The patient's liver function test is suggestive of a total bilirubin of 15.5 and a direct bilirubin of 12.2 milligram per deciliter, which is more in favor of a obstructive pattern of jaundice. And patient's serum albumin is 3 grams per deciliter. For total bilirubin and direct bilirubin, sir, at this point, we might not do anything because depending on the imaging, if the patient is whatever findings we get, if the patient is resectable or not, we will plan for biliary drainage likewise.
So, Milan, if with this kind of a scenario, the patient on investigations is operable. Operable, what do you mean by operability for a periampullary?
Sir, not operability, resectability, I meant.
Yeah, resectability. So what do you mean by resectability on imaging?
So on imaging, sir, usually the best form.
I say the patient is resectable on imaging. So would you like to resect this patient and get
Sir, not as of yet, because conditionally the patient is not fit for surgery at this point, sir. We'll need to optimize the patient conditionally.
Dr. Milan, thought process.
Yes, sir.
You're in the right direction. Good.
Yes.
It's just the parameters let you know that where you are heading towards. That's exceptionally good. Yeah.
So next, we also see that the patient's PT-INR is deranged, which is suggestive of a underlying coagulopathy. So the patient might require vitamin K administration for 5 to 7 days. And again, after repeating a PT-INR, we'll have to see whether we can correct the we have corrected the coagulopathy or not. If not corrected, then the patient might require a transfusion of fresh frozen plasma to further correct the coagulopathic state. And also, sir, the patient's viral markers are positive. So we will need to identify which viral marker in this patient is positive. And if the patient is positive for any kind of hepatitis, he might require pre-treatment treatment.
So you would like to know viral load, get on a medical gastroenterologist to have an antiviral medication started because it has its own repercussions.
Yes,
we skip the tumor marker, I suppose. What is your take on a tumor marker CA 19.9, which is 111 marginally elevated?
Yes, sir.
A threefold elevated. What is your interpretation on it?
Sir, CA 19.9 is, sir, its role in any form periampullary carcinoma is it's doubtful, sir. It's actually debatable. It has prognostic role. Like after we can do a baseline CA 19.9, and then after treatment we can follow the reduction in the CA 19.9 level to see if
Are we
holds any
contradicting our statements? You had a bilirubin of 15.5.
sorry,
Yeah.
sir, sorry, sir. Yes, sir, yes, sir.
Yeah.
CA 19.9, sir, elevated in the presence of obstructive jaundice is not specific, sir, because it will be elevated in any form of cholangitis, inflammatory condition, or an obstructive pathology of the biliary tract. So we have to repeat a CA 19.9 post biliary drainage, and that will serve as our baseline CA 19.9 level, and that can act as a prognostic marker for our further treatment planning.
Very good. So it's always an interpretation of a tumor marker is post biliary drainage, not
Yes.
at the baseline in an obstructive jaundice patient. Yeah?
Yes, sir.
Dr. Kalairasan, any insights on the parameters you would like to have a discussion?
Dr. Akshay, Dr. Milan mentioned CA99 is a prognostic marker.
Yes.
Okay. So can you just elaborate on that, how it is a prognostic marker?
Sir, patients with CA125-11, CA99, more than 1,000 have a very poor prognosis, sir. And patients with values between 500 to 1,000 are considered borderline resectable. And after surgery, patients who have CA19-9 elevation are again considered to have a poor prognosis, and it becomes an indication for chemotherapy if patient one more indication for chemotherapy after neoadjuvant.
No, what high level of CA99 does to the body which results in poor prognosis?
Sir, higher level of CA 99 are just indicative of a more advanced nature of the disease. So for levels of more than 1,000, it is indicative of, it might be indicative of a disseminated disease, or for even for, as a matter of fact, even for levels of more than 150 or 200 are suggestive of, which can be suggestive of disseminated disease or metastatic disease, and it hints. It gives us a hint that we can plan such a patient for a diagnostic laparoscopy prior to proceeding for any kind of major resection in the form of surgery, sir.
What do you understand by biological criteria for resectability?
Sorry, sir. Sorry, I didn't get you. Sorry, sir.
What do you understand by biological criteria for resectability for pancreatic cancers?
Sir, in biological criteria for resectability of cancer, sir, the level of CA 99 has been evaluated, sir, in this scenario. So, sir, in one of the studies done, they had taken various levels of CA 99 starting from 100 itself. And then for less than 100, 100 to 500, 500 to 1,000, and more than 1,000, they had seen how it affected the overall survival or outcome of these patients. So it showed that with rising levels of CA 99, the outcomes were worse. So it is basically a higher CA 99 level will.
So how does that change your management strategy for these kind of patients with high CA 99?
So our only management strategy that is high CA 99 level will change is that for levels of more than 100 to 250, one range is there, sir, which can guide us to do a diagnostic lab prior to taking the patient up for a major resection, sir, to rule out any metastatic disease in that case.
Yeah, that's the only difference that will make it to the management. You will just undergo a staging laparoscopy. Would you like to subject patients with high CA99 levels to some other form of treatment other than surgery?
So, for sir, role of CA99 in deciding the role of neoadjuvant chemotherapy in patients is not very clearly defined, sir. The only other form of management which can be done is, which can be planned for these patients is subjecting them to neoadjuvant chemo, because if they come into the criteria of borderline resectability, then we can plan for a neoadjuvant chemo for these patients.
Right. Can I go to the next slide?
Yes.
Yeah, for sure.
Yeah. So which is the first choice of your modality, and how do you choose your modality of imaging?
So the first choice of imaging in this case would be an ultrasound of the abdomen.
I would like to do a PET CT scan now. That will give me an idea about the tumor as well as the spread metastasis. So, do you agree with me, Dr. Milan,
sir.
Dr. Arvind?
No, sir.
Why unnecessarily waste so much of time on other investigations? I directly go for a PET CT scan.
Sir, a PET CT scan is not going to give us any additional information over a pancreatic protocol CCT of the whole abdomen along with a CCT thorax done. It would.
So, what do you understand by a pancreatic protocol CCT?
Yes, sir. So, a pancreatic protocol CCT scan is a CT scan modality which is done using a water soluble using water as a negative contrast to delineate the duodenum during the scan, along with a non-ionic iodinated contrast, which is used, which is given fast at the rate of 3 to 5 ml per kg. After that, cuts are thin slicer, sub-centimetric slices, that is 0.5 to 1 mm of slices are taken, and it is divided into 3 phases, sir. First is an early arterial phase, which is taken.
Are you sure the pancreatic protocol is a 3-phase scan?
Sir.
Dr. Arvind?
Sir, it's a neutral contrast.
No, I didn't ask about the contrast. I asked about the phases.
Is it a dual phase or is it a tri-phase? Is what?
Yeah, Dr. Sakur has already given you that.
Yes, sir. It is a.
Yeah.
So, dual phase or a tri-phase? And where do we use a tri-phase?
Sir, in liver for hepatic malignancies, we use a triphasic, sir.
And for pancreas, what do we use?
Sir, pancreatic phase and portal phase. Sir. Portal
yeah,
phase.
so the dual phase.
Dual phase.
Yeah. Then, what else?
Sir?
What else do we mean by pancreatic protocol CT?
Sir, the phases that we mentioned, so the pancreatic phase and the portovenous phase, they are taken at 30 to 40 seconds, 30 to 45 seconds for the pancreatic phase and 60 to 70 seconds for the portovenous phase, sir.
Dr. Milan,
yes.
May I make a comment?
Yes, sir.
What do you understand by early arterial phase? What do you understand by pancreatic parenchyma phase and portovenous phase? What is your understanding, and how do you pick up that what image you're seeing is exactly in that point in time? Leave alone this 45 seconds, 70 seconds of installation or administration of contrast.
Yes.
But when you look at the image, how do you pinpoint and say that this is it? This is an arterial or an pancreatic parenchyma phase or a portovenous phase? Just one hallmark of both. What is it?
So in the arterial phase, the aorta will be opacified very strongly, sir. In the early arterial phase that we are talking about, sir, that occurs at 10 to 15 seconds.
Very good. So when do you want this phase?
Sir, at this point, we are trying to trace the upper abdominal vascular anatomy, sir. The anatomy of the...
What are you interested in?
Sir, the superior mesenteric artery, the common hepatic artery, and our celiac axis, sir. These 3 I'm interested in when I'm taking a early arterial phase, sir.
Apparent vascular, sir.
Yeah, what are the common anatomical variations that you see in the arterial system for a pancreatic?
Most common is the aberrant right hepatic arteries. The 10 to 15% of individuals, it arises from the superior mesenteric artery. And the second is apparent left hepatic artery. And the third most common is accessory right hepatic arteries.
Aberrant left hepatic artery arises from where? You said
the left gastric artery.
Yeah, so you should be careful when you're doing your T2 gastrectomies.
Yes.
For a Whipple procedure, it is a type 3, I guess, which is more important. Yeah. So in what is your understanding about pancreatic parenchymal phase? What is that you're looking at?
Sir, in the pancreatic parenchymal phase, we are trying to look for any lesions in the pancreatic parenchyma. basically at this point, any pancreatic mass which appears as, we can differentiate them as hyperattenuating and hypoattenuating depending on its comparison with the remainder of the pancreatic parenchyma. It will give us a suggestion as to what kind of mass we are dealing with, or what kind of pathology we might give an indication to the type of pathology we are dealing with, sir.
So why at 45? Sorry.
Hey, good.
Why at 45 seconds? You want to come to a conclusion at 45 seconds, right?
Yes, sir. Sir, I'm not sure. Sorry.
Yeah, the idea is it takes about 45 seconds for the contrast to reach and enhance the parenchyma substance of the pancreas. And that is a comparison what you're making, your lesion versus the parenchyma. Okay. So
Yes,
that's
sir.
how we come to a conclusion saying that at 45 seconds we do it. Added value you get about arterial, that is 20 seconds, is you also have to look at, it is predominantly for delineating the vascular anatomy, also to add aortic aneurysms, dissections, which are unnoticed at times. Yeah.
Yes, sir.
Dr. Vikas, if you could
Yeah,
add in.
Dr. Milan, you mentioned that you will give a negative or a neutral contrast orally.
Yes, sir.
If I give gastrographin or I give a positive contrast, won't that help me in delineating the duodenum better?
Sir, but then it will be difficult for us to differentiate it from the pancreatic parenchyma, sir.
No, why do I need to differentiate it from the pancreatic parenchyma? It will help me to delineate the duodenum better. No? I'll give a oral positive contrast. I'll give gastrographin. So why do you specifically want to give a negative contrast? For gastric malignancies, for stomach, we give a positive contrast. But for perium, why do we stick to a neutral contrast? Dr. Arvind?
Not very sure.
Sir,
What are your size of?
Yeah.
Sorry, I think they're overlapping. Sorry. Yeah. Please go ahead. Dr.
So
Vikas.
basically, what here we are looking at, we are more interested at the interface. So whether the tumor is going into the vessels or not. So when we have to appreciate the interface between the vessels and the tumor, so if I give a positive contrast, there will be an overlap. So I would not be able to define the vessels, and there could be some streak artifact as well.
Yes, sir.
So that's the reason why we give a neutral contrast to delineate the vessels as well as the tumor and the duodenal.
Yes.
Yeah.
What has been the practice at your institute? What negative contrast and what is the section size? Is it 3 millimeter, 2 millimeter, 1 millimeter?
Sir, at our institute, we give mannitol as the negative contrast that is given orally. And
what are the other negative contrast you know of?
So water can be used, sir.
Water and even air is a negative contrast. No?
Yes.
Dr. Kalairasan, would you like to add in for the CT pancreatic protocol?
I think the early arterial phase, is added in addition to, I mean, the pancreatic phase is actually the late arterial when the pancreatic parenchyma enhances well, but when there is suspicion of neuroendocrine tumors, so then the early arterial phase plays an important role because they enhance well in the early arterial. I was just, because I think one of the aim is to give the right answers also. So the question which I asked actually, Dr. Akshar, I didn't answer about that CA19 and why the elevator level is considered as poor prognostic marker, because if you actually see the CA99, they're expressed on the tumor cells. So, and that helps the tumor cells to platelets and the other blood cells and help in the metastatic spread. So when the CA99 level is elevated, so in addition to all those things, like it is a reflection of tumor burden, it actively helps in the metastasis of the tumor cells. So that's why the high levels are considered as a poor prognostic marker, and then you actually look for sites of metastasis. Yeah, sorry, because I thought I forgot to answer that time, so we moved, so I shouldn't forget it. Okay.
Dr. Kalai and Dr. Vikas, with your permission, if I can, in the interest of time, I think we are just left with another 10-15 minutes. If I could just get straight to the particular points with indications, contraindications, and I just
I'll just
through
ask
the,
a brief question. So, would you like to do an MR in this patient? More pertinent, Dr. Arvind?
Sir, MRI is usually used as a problem-solving tool. When we have a
No, in this patient in particular, I'm interested.
In this patient?
Yeah.
Sir, in this patient, we are not sure about the level of obstruction, sir. If it is a periampullary pancreatic protocol, sir, if
there's something else that might because the patient is having a high creat, borderline creat.
Yes, sir. If you cannot give a contrast, then compared to a plain CT, MRI plane is better in delineating soft tissues. So MRI will be a preferred modality.
Anything else? So if there are indeterminate liver lesions, that can be picked up better with an MR than a CT. Fine.
Right.
Yeah.
Indications of PET CT, Dr. Akshar?
Sir, PET CT.
For example, I'll just tell you this. Patient, as Dr. Vikas said, patient has come to you with a PET CT. Would you still repeat a CT or you're happy with the PET CT? This is a kind of a real-time scenario, how you get to see the patient sometimes.
Sir, we need a pancreatic protocol CT to look for resectability, sir, to assess the anatomical resectability of the patient. PET CT is again used to solve the intermediate lesions, sir. So if we are having any suspicious lesions in the liver, suspicious non-regional nodes, then we can do a PET CT to confirm whether it is due to a disease or artifacts.
See, the three indications, straightforward indications for MRI, the 3 to 4 straightforward indications for PET CT, 2 indications for MRI has been covered. Third indication, can you tell for MRI?
Smaller lesions, sir.
The lesions which are not picked up on your routine CT, but there's a high suspicious of malignancy, would do an MRI. PET CT, similarly, do you have clear-cut indications?
So one indication for PET CT could be in the setting of when we are planning the patient for a neoadjuvant treatment for response assessment to the treatment we can.
And your level of evidence for it is? It's a category 2A level of evidence. So yes, to consider it, what are the other indications? Well, he added up, just to summarize him, whenever you're suspecting an extra pancreatic disease in terms of large primary, large nodal disease, you can consider PET-CECT. Yeah, PET-CECT is not a substitute for an CECT. It can be used an adjunct procedure along with the CECT. Quickly moving on to US. When would you do an US? Dr. Akshar, you could take it.
Sir, after pancreatic protocol, we'll do an endoscopic ultrasound, sir. In endoscopic ultrasound,
Dr. Arvind, for routinely all the patients of periampullary malignancy, you do an endoscopic ultrasound?
Dr. Milan, you could take the question. Indications for endoscopic ultrasound.
So suspicious nodes, smaller lesions, and for ISO-intense lesions in pancreatic protocol.
Okay.
And for smaller lesions and to target suspicious nodes, we can take an US-guided FNA.
What nodes would you like to target?
The level of obstruction, sir. We can check the level of obstruction, sir.
No, you said you want to target some nodes. Is there any specific nodes that you'd like to target in US?
Sir, EUS can also, apart from when we have equivocal findings on other forms of our imaging imagings, then we can do an EUS to confirm the site from where whichever the lesion might be arising. Apart from that, it can also give us an idea about the vascular anatomy around the mass with its the relation of the mass to the surrounding vascular anatomy, and it can help us get tissue for diagnosis, sir, in the form of EUS guided FNAC from head of pancreas lesion if there is one, and
Fine.
Right. Dr. Kalairasan, your take on imaging, would you like to add in anything?
No, I think fine. We can just go ahead. Yeah.
Right. So that's been the image of the patient. Dr. Milan, could you have a check and let us know? I'll run it slow for you. Which phase is this, Dr. Milan? If you could identify which phase?
So this is the arterial phase, sir, as we can see by the enhancement of the abdominal aorta. And no, sir.
Even though
It's not, sir.
I'm okay. I'll break the ice. I've not taken the arterial. I've just gone for the two other. Yeah.
So there is a. This is.
Let me know when you want me to stop the cursor. I'll stop it over there. I'm drawing it back. I'll just draw it again.
So this is the pancreatic phase of CT, sir, as we can see by the enhancement of the pancreatic parenchyma.
Okay.
And sir, in we can see some intrahepatic this biliary radical dilatation is evident, sir. And
okay. So how do you make your checklist when you read your CT scan? Would you start from a duct, artery, vessel, primary, nodal part? You have a checklist of reading. You have a template.
Yes, sir. Usually, sir, first and foremost, we start with looking at the vessels, sir, in the CT scan. Followed by we look at the sir, any signs of gross lesions that are visible, which might be suggestive of the primary. Then we look for lesions which are suggestive of the stage of the disease, sir, like in the form of any other extra maybe hepatic lesions or ascites or any lymph nodal mass which may be present in the.
Okay. Right. I give it to you. Can you interpret this on the same background? Could you tell me about a CBD? Could you tell me about the pancreatic duct? Could you tell me about the vascular anatomy and the primary?
Yes, sir. So the CBD in this section appears to be dilated, sir, in the pancreatic parenchymal phase. And
are you able to appreciate a pancreatic duct?
Sir, not very clearly, actually, sir.
Yeah, I would say it is here.
Yeah. So you have a clear
small.
Okay, sir.
Okay, right.
Yes, sir.
Okay, then I'll take you to the primary.
Yes, sir.
Yeah.
Primary.
Yes, sir.
Yeah, what is your interpretation?
So there seems to be a suspicious lesion arising from the sir, at the second part of duodenum, sir.
Very good.
It is intraluminal, sir. There is intraluminal extension of that lesion, and
right. Okay, good. I'll just run the other picture. Can you identify what phase is this and justify what phase it is? I gave you a hint. I said I've not included arterial, so this has to be portovenous. If you could justify why it is portovenous, I think we are done with this.
So because we can see the portal vein anatomy and the venous anatomy clearer in this, as
Which
is
venous?
evident. Sir, Sir,
Which way? Which way?
Sir, the two important veins that we need to look in this phase are actually the superior mesenteric vein and the portal vein, and its relation to the mass, basically.
No, I meant if you have to justify, always look for the complete enhancement of the venous system, that is hepatic veins and the
So IVC.
portal vein.
Portal vein. Portal vein.
Portal vein.
Yes.
Portal vein, and that's a portovenous phase for us. And
Yes.
I think it was covered that this is predominantly done to identify indeterminate lesions or the liver lesions. Okay.
Yes, sir.
Akshar, can you take this please? Can you identify any arterial anomaly you know of? You can spot in this.
Yes.
I think Dr. Vikas engaged in a conversation with regards to this.
Yes.
Just let me know if it is too quick. I'll pause wherever you feel like. I'll take you to the maybe from there.
Yes,
Start with the hilum. I'll run it quick again.
Sir, too fast for me to read.
Sir, is it a right hepatic or
Too fast. Okay, you didn't notice.
Sir, can you show the celiac trunk?
Excellent.
Sir?
I give it to you. Yes. Oh, great. Yeah. That's your celiac trunk?
Celiac trunk, right, sir?
Yeah.
Sir.
You can see the...
Right. Okay, that's a SMA which is coming in. How do you say that it is SMA? Is there any landmark for you? Apart from saying that it is a second tributary, always look for the left renal vein crossover. So this image, just for the want of time, I'll skip through. This image has gotten type 3, that is right hepatic artery arising from SMA, and this image has gotten a common hepatic artery arising from the SMA. Just to reiterate, Dr. Vikas, it's very important that you identify the vascular anatomy, because in 45% of the case, the vascular anatomy is normal. In rest 55% of the patient, it is abnormal. So you need to also be prepared for Michael's classification of hepatic variations, knowing that every second patient, what you're seeing might have an aberrant arterial anatomy. So this patient had gotten an endoscopy done elsewhere, and he had presented to us. And a biopsy was, endoscopy said that there was an ampullary ulceration. Biopsy was inconclusive. Is there a real necessity for having an tissue diagnosis in an imminently diagnosed of a periampullary tumor, or what are the indications of tissue diagnosis? When would you ask for a tissue diagnosis?
Sir, a few
Dr. Milan, you could take it.
Yes, sir. So, few specific indications of getting a tissue diagnosis is, so firstly, if we are planning the patient to undergo a neoadjuvant treatment prior to...
Just sorry to interrupt. Dr. Milan, just you see the finding now.
Yes, sir.
Okay. So you are seeing a lesion. Now the endoscopist is asking you, you want me to take biopsy or you don't want? So what you'll tell?
Sir, actually, I'll tell the endoscopist to take a biopsy at this point. Because in previous biochemical analysis, we saw that the patient is not conditionally fit to undergo any kind of major resection at present. So it might take us few weeks to optimize this patient to come up to any form of surgical resection. So if we get a biopsy in the meantime.
No, but how the biopsy is going will help in optimization? So you want to say if biopsy is negative, you want to optimize?
No, sir, we'll optimize in both cases. Sir, I confused with the
neoadjuvant. You have to reword whatever you said.
Yes, sir. So actually, if what I wanted to say was, if it is going to take us some time.
No, here the thing is, the point is different here. So you are seeing a lesion.
Yes, sir.
So you will take a biopsy or not? Whatever
Yes,
you say, you need to justify.
So we will take a biopsy, sir. The lesion is there, we'll take a biopsy. It is
reason.
So to get a tissue diagnosis, I would like to have a biopsy.
So I will frame the question in another different format.
Yes.
With a perimelinary, in a suspected case of perimelinary malignancy, which cases where will you ask for a biopsy and which cases you like to operate upfront?
Sir,
Dr. Arpit? In a case of suspected periampullary malignancy, what are the scenarios in which you like to operate the patient upfront and where would you like to take a tissue biopsy?
Sir, tissue biopsy is actually not necessary for taking the patient up for any kind of surgical procedure. We can take the patient for surgery directly without having any tissue diagnosis also, but we'll have to keep the patient informed that there might be chances that post-operatively the histopathological report might come back as negative.
So if you have a jaundice patient
Yes.
with a suspected malignancy and the patient is optimized for surgery, you can operate the patient.
Yes, sir. We can operate the
Yeah. Just I'll add my point regarding this. So now there's a lesion seen. So in this case, I will tell my endoscopist to take a biopsy. The reason is because there are some cases where you will have an alternate diagnosis, which will not require PD. Like, no, I'm telling from our experience. So we have a couple of times it came as lymphoma. So which the treatment is different.
Yes.
Okay. So,
yes,
and you can have tuberculosis.
Yes.
So where the treatment is different. So that is one of the reason.
Yes, sir.
You take biopsy. And obviously, when you have a positive diagnosis, you will be able to better counsel the patient. So this is the reason you take a biopsy when you see a lesion.
Yes.
But on the other hand, for example, it's like a lower end cholangiocarcinoma, okay, where taking a tissue diagnosis is going to require more effort, like doing a EUS. And so in those cases, we don't take additional efforts to prove the diagnosis if you have otherwise decided to go with surgery. Okay.
Yes.
Unless like if I'm contemplating neoadjuvant, then I'll take an extra effort to make the tissue diagnosis. But if I decide to go out with surgery, then we won't take extra effort to prove the diagnosis, because even if the diagnosis comes negative, if the other findings are suggestive of malignancy, we are anyway going to go out with surgery. But if you are seeing a lesion, you will always tell them to take a biopsy. Okay.
Yes.
Right. I'll go to the next slide. So, what's your plan, Dr. Milan?
Yes, sir. Sir, next, sir, firstly, I would like to optimize this patient for any kind of treatment, sir. As I had told when we saw his biochemical analysis, sir, from his hemogram and LFT and liver function test and the kidney function test. So the patient requires optimization in that sense. And also, sir, this patient has presented to us with obstructive jaundice with intermittent fever, which is suggestive of cholangitis. So in this case, I would like to consider this patient for a biliary stenting prior to biliary drainage procedure, prior to any form of treatment, any form of treatment which we will give for the same to this patient ahead. So, sir, once we have
I'll just cross like this.
Yes,
Patient
sir.
in a good performance status and asymptomatic, no intense pruritus. Bilirubin as a number is 15. Good PS. Would you divert or wouldn't you divert? That's the only biochemical parameter which is on a higher side as albumin, globulin, everything is within normal parameters.
So with the bilirubin of 15 and patient being in a good performance status with all other parameters optimized, I would not like to subject this patient to any form of biliary drainage and take the patient up for upfront treatment, sir, whichever modality we are using.
So having said that, what are clear-cut indications for a biliary diversion? One.
Yes, sir.
What is the kind of stent you utilize?
Yes, sir.
Two. Is it a covered stent or is it an uncovered stent? Can you
yes, sir.
The questions one after the other?
Yes, sir. Sir, first answer to the question of when would we like to divert the patient? When would we like to consider for biliary diversion? So, few indications for biliary diversion are one is when the patient is not optimized for any form of treatment. Like in this case, the patient has a low hemoglobin, patient does not have a good coagulation profile, his renal functions are not within normal range. So we would like to consider this patient for biliary drainage. Also, if we are thinking that we might not be able to take this patient up for surgery in the coming 1 week to 10 days, if the surgery is going to be delayed for any reason, we might consider for a biliary drainage. And for a patient who is in active cholangitis, we would always like to consider for biliary drainage prior to taking the patient up for any form of treatment. Next, coming to the question of
there are a few indications that you have missed for preoperative biliary drainage.
Dr. Vikas, could you come again?
There are a few other indications for preoperative biliary drainage that she has missed.
Sir, another one would be, so when we are planning to start the patient on neoadjuvant.
Yeah, that's one indication. Yeah.
Yes, right. Then we'd like to drain the patient. And
there is associated hepatic dysfunction. So to relieve the hepatic dysfunction, that could be one indication. And in some cases, intense pruritus.
Yes, sir. Yes.
Intractable pruritus. That is an indication for biliary diversion.
Yes, yes, sure. So then for the type of stent, type of drainage, the type of stent that I would prefer. So when we are considering drainage for a short period of time, for a shorter duration, a plastic stent can be used when the drainage is for 10 to 14 days. Otherwise, SEMS placement is better, sir. And in SEMS also, a covered SEMS would be a better choice than an uncovered SEMS, because for an uncovered SEMS, the removal of the stent becomes difficult because of tumor ingrowth into the stent. In a covered SEMS, we will not have tumor ingrowth, so it can be easily removed during surgery, sir.
I think, Dr. Milan, you are getting it wrong again. So when do we use a cover stent and when do we use a uncovered stent? And we prefer metallic stents for all the cases. Only for economical reasons we use a plastic stent. Metallic stents are always preferred, and covered stents we use in cases.
Neoadjuvant.
Yeah.
Neoadjuvant treatment.
Very good.
Yeah.
Uncovered.
Why is that?
Sir?
Why is that? Can you reason out?
Yeah.
I think Dr. Vikas brought out the message saying that short SEMS are the ones which are preferred over a plastic stent, keeping in mind the commerce.
Yeah,
and whether it is covered or uncovered, which one is the preference? You have to justify which one you are opting for.
So if
where stents do not migrate,
so if you are using for a shorter duration, we can. Yeah, for a shorter duration, we always prefer an uncovered stent. But if you are using it for a palliation, where we don't anticipate any surgical procedure in the future, or we are using it for a permanent palliation, then we prefer a covered stent, so that there is tissue ingrowth.
Dr. Kalairasan, your thoughts on biliary diversion stents and covered versus uncovered, what are your take?
Yeah, I think I agree with, like, unless we are looking for like in the neoadjuvant setting, so where the duration of where the patient requires a prolonged biliary drainage, so there prefer to have this short SEMS. Otherwise, the plastic stents in a routine preoperative biliary drainage done for cholangitis or the optimization.
Dr. Akshar, your endoscopist is doing the ultrasound, scopy, and he asked for what is the SEM size you want. What is your recommendations, or what is your preference? 4 centimeters, 6 centimeter, 8 centimeters?
Normally we use a 10 French stent as we use.
No.
Okay, if it is an
So Dr. Sukar is asking the length of the stent. How long will you like to have the stent?
I use
Dr. Kalairasan has already given you the answer. Sure.
For a neoadjuvant therapy, if you are going to operate on the patient, we use a short stent.
Yeah.
what is that? What is the dimension of it? When you say short, what is your understanding? You need to explain to your endoscopist also. So what comes to your mind? What number is in your 468? So it's approximately 6 centimeter. 4 centimeters are prone for migrations. 8 centimeters are higher up than the cystic duct insertion. So preferably 6 centimeters. When else you will stent your pancreatic duct? Do you stent your pancreatic duct?
So
Often you see like
having
people coming with a pancreatic
concomitant
duct.
pancreatitis, then we can stent the pancreatic duct also.
Sorry, come again.
Persistent pancreatic.
So because of the duct obstruction, if the patient is having pancreatitis or then we can stent the pancreatitis.
Is it a indication?
Sir, in cases where we don't resect, sir, in unresectable patient as a part of palliation, we can put it.
Sorry, I understand.
Sir, and it helps in improving the nutrition, sir, because of the exocrine insufficiency also.
Persistent chronic pain due to pancreatitis is one of an indication for pancreatic stenting as per recent NCCN recommendations.
Sir, and it will also help to improve the nutrition by improving the exocrine function of the pancreas.
Right. And can we go on to the surgical part, Dr. Kalai and Dr. Vikas?
Dr. Pawan, we are way beyond time. If we can conclude the case mock exam in the next 2 to 3 minutes, we'll move on to the other aspects of the webinar.
Okay, right. So, Dr. Kalai, you can take up for the surgical part of management.
So, in this case, now you are planning what would be your preferred procedure?
So, considering it to be a case of a resectable periampullary carcinoma, I would like to prepare this patient for a pancreaticoduodenectomy surgery, sir.
So, pylorus preserving, pylorus resecting, or a classical?
Sir, we usually prefer doing a pylorus preserving pancreaticoduodenectomy at our institute. However, since this is a case of a duodenal malignancy, sir, so I would like to go for a classical pancreaticoduodenectomy in this case, sir.
Dr. Milan, Dr. Collerson added one word, pylorus resecting pancreaticoduodenectomy. So, what do you mean by a pylorus resecting pancreaticoduodenectomy? Is it the same as classical ripples, or is a difference?
So there is a difference in pylorus resecting in which the sir, I'm not sure about that procedure, but there is a difference.
Dr. Arvind, would you like to add something?
I don't know.
So the difference, yeah.
Yeah. So basically, because in classical, so the extent of stomach which is resected, it is something like a hemigastrectomy. So that was what done in a classical pancreatenectomy. But you don't have to resect that much of the stomach. So the people who don't do pylorus preserving because of the concerns, either with respect to the ischemia to the pylorus as one of the reason for delayed gastric emptying, or in, as you told, in some of the advanced cases where you want to have a wider margin. So there, as a balance between pylorus preserving and the classical PD, you do a pylorus resecting, which means you just divide the stomach 2 centimeter, roughly 2 centimeter proximal to the pylorus. So you just resect the pylorus, but you preserve the whole of the stomach. So it is called as pylorus resecting, or other names are subtotal stomach saving pancreatenectomy. SSPD. So various terms are there, but the principle is you don't have to resect half of the stomach. I think probably
Dr. Vikas, would you like to engage them in a discussion for intraoperative management?
So if you are operating on a jaundice patient, what are the things that you like to tell your anesthetist? What are the precautions that you like to take?
His cardiac stroke volume will be lower, sir, and he'll be more prone for hypovolemia intraoperatively. And again, because of bile acids, his renal function will also be treated. So it should be a zero negative balance fluid resuscitation intraoperatively, sir. Keeping in mind the patient does not have adequate response to catecholamines if at all the patient goes for a hypotension during intraoperative.
Fine.
What all parameters do you consider while you're doing your PG or PJ? What is your thoughts on pancreatic fistula risk score? What are the parameters which are included, and what is the scoring part on the back of your mind when you are managing a case post-operatively?
So there are 4 parameters that we take into consideration while considering a post-operative pancreatic fistula score. So first is the texture of our pancreatic gland, the type of texture. So second is the size of the duct that we get intraoperatively. So next is the amount of blood loss that happened during the surgery. So, and then there is the pathology of the disease. So these are the 4 parameters that we take into consideration. And then depending, sir, we get a score ranging from 0 to 12. And it is divided into low, moderate, and high risk for post-operative pancreatic fistula. So depending on what score we get.
Is there an intermediate?
Yes, sir, there is an intermediate
I
risk.
think it's low, moderate, intermediate.
So low, intermediate.
So if it is a high risk, so what's the intermediate score and what's a high risk score, and what is your analysis if you have a high risk score? The morbidity goes up to how much if you have a high risk score? So intermediate is a 3 to 6. Anything above 6 is a high risk. So the morbidity goes up to 30% is the thought process. Dr. Kalairasan, any thoughts of yours?
No, I think
And prophylactic octreotide can be given for high fistula
Hey,
stroke.
but has that been proven useful in any of the studies, prophylactic octreotide?
Certain studies they have shown that in high pancreatic risk score fistula risk score patients, octreotide may reduce the morbidities of the fistula.
Okay. Sorry to interrupt, examiners. If it's okay with the moderator, do we have permission to conclude the mock exam with some concluding comments from the examiners?
I think yes. I think we ran out of time, I guess, right? Yeah, we overshot. Yeah. Well done, both of you, Dr. Milan and Dr. Shekhar. It's Akshar. It's very good. Keep it up.
Thank you, sir. Thank you.
Right. So thank you, all the 3 examiners. Actually, this was a very nice mock exam where we discussed each and every part till this discussion point in detail. And I think because we do multiple of these programs over the years, in every webinar, there's a different aspect of the subject that gets discussed. And that's why these students will benefit if they go back to YouTube and see all the webinars of the same topic in succession. Thank you, examiners, again for this excellent session. We move on to our next segment, which would be the expert talk. And before I do that, I invite Dr. Venkat Chala from the team of NatCon 2024 from Bengaluru to kindly do the announcement for NatCon 24 from their behalf. So on behalf of IASO, invite all the residents specifically to register for the conference and send in their abstracts, exciting awards and fellowships which are provided by IASO. Dr. Venkatchala, are you there?
Yeah, I am here very much.
Sir.
Yeah, thank you very much. I would like to invite you all for the NatCon 2024, which is organized at Bangalore. And it is the biggest conference of surgical oncologists in India. For all those who have already registered, close to 600, we are very thankful to them. For those who have not registered, why you should register? One is it's your own conference, so you have to attend. Second, Bangalore is well connected from all across India. You cannot give excuse of travel problems. Third, there are lots of awards sponsored by IASO body as well as NatCon awards. Close to around, if you can see, around 65 awards have been offered by NatCon itself. Along with that, there are SSO awards, Detroit Fellowship Awards, and Baroda Fellowship Awards, SSO Poster Awards. You can at least get back what registration amount you're going to pay for this conference. So it's going to be a very big academic event. Please don't miss out. Please come in good numbers. Please submit your abstracts as soon as possible because the deadline is July 31st. And we need time to also scrutinize the abstracts and also communicate to you, and please register as soon as possible and send your abstracts at the earliest. Thank you very much.
Thank you, Dr. Venkatchala and the team at NatCon 2024. We move on now to the expert talk by Dr. Kalaiarasan Raja. Sir, can you share your screen, and we're all ears for your expert talk.
Yeah, thank you, Dr. Srijan, and I thank IASO academic committee led by Dr. Subramanian Rao for the opportunity. So I think next 25 minutes, I'll cover this updates in the management of periampullary tumors. So I thought since it's a vast topic, so probably instead of touching upon many aspects, so I thought I'll cover probably 3 or 4 aspects, which there are some controversies, which as a resident, they should be knowing, what is the current evidence tells, and how to optimally interpret the evidence. So since many are postgraduates, so I thought cover also a bit of basics, something which they should know about this periampullary tumors, and the current evidence with respect to the neoadjuvant therapy. And often we talk about mesopancreas, so what it means, and obviously the minimal invasive approach, what is the current evidence in the management of these tumors. I think this, we all know, we are very familiar. So the periampullary tumors, there are actually 5 distinct. So although they are anatomically 4, but if you see the ampullary tumors, the intestinal subtypes and the pancreatobiliary subtypes, they actually behave, they have a distinct outcomes with respect to even the short-term and also the long-term outcomes. Overall, if you see the common type is pancreatic cancer, but in the surgical series, the ampullary tumors are the common type because they are the often resectable compared to the pancreatic cancer, which are unresectable. And if you see them, actually the 5 types, although they are in a very anatomically close region, but if you see the behavior and even the short-term outcomes, they are distinctly different. So they're more of a different families than being siblings. And this is a paper published this year. It was actually an international multi-center cohort study. So analyzing the short-term and the long-term outcomes. If you see the post-operative morbidity is lower for pancreatic cancer, not difficult to guess. That's because often the morbidity in pancreatic, morbidity following pancreatic is often due to the pancreatic fistula, and pancreatic cancer, the ducts are often dilated, the gland is firm. So usually the morbidity, the surgical technique or the procedure steps might be difficult if there is vascular involvement, but often the anastomosis is straightforward, and because of that, the post-operative outcomes also are better. Whereas in ampullary tumors and others, you have high post-op morbidity. Also, if you see the survival, it is best in ampullary, especially the intestinal subtype. It's not the pancreatic biliary subtype. In fact, the ampullary tumors with the pancreatic biliary subtypes, often the gland is firm compared to the intestinal subtype. And that's why the ampullary tumors with the pancreatic biliary subtype, the pancreatic fistula rates are much lesser than the intestinal subtypes. So this is which you should understand about the short-term and the long-term outcomes with these various subtypes. This is very basic. We always talk about this Courvoisier law, but as you see the original description, he never stated it as a law. If you see Newton's first law, second law, that is different. But here it is actually a finding from around 187 patients, 87 related to stone and 100 other causes. And he has found the gallbladder is often distended in a patient with the malignancy, whereas in stone disease, it is not palpable or distended. So it is often not palpable. So ideally, it should be called as a sign. So whenever we talk about exceptions to Courvoisier law, we are actually not telling the right thing because he never intended it as a law. It is actually a finding. So the sign is the correct term rather than stating it as a law. And many times in periampullary tumors, I won't tell this many times, in a patient with obstructive jaundice. So there are situations where it is due to lower end obstruction as in periampullary and also in hilar obstruction as in hilar cholangiocarcinoma. Often in hilar obstruction, you see white bile, but even in some instance of lower end obstruction, you would have seen white bile intraoperatively. It is different from the mucosal of the gallbladder. So what I meant is you cut the bile duct and you see the white bile. So why it happens? Why it often happens in hilar obstruction and less commonly in lower end obstruction? Because in lower end obstruction, you have the gallbladder, which is usually functional. So even though there is a lower end obstruction, because the gallbladder, it keeps on concentrating the bile, and the pressure gradient is maintained so that the bile which is produced by the hepatocytes and secreted into canaliculi, it keeps flowing downwards. But in hilar obstruction, many times, because the obstruction above the level of the gallbladder, the concentrating ability and the ability of the gallbladder to maintain the pressure gradient is lost. So the pressure within the biliary tract exceeds a critical threshold beyond which whatever bile is secreted into biliary canaliculi cannot flow downwards, but it reflexes into the portal circulation. So when you see a white bile in a patient with lower end obstruction, it indicates the gallbladder has lost its concentrating ability. And white bile does not have bile pigments, bile salts, or cholesterol. And usually that is just the biliary epithelial, the ductular secretion. And sometimes you see black bile. Black bile is nothing but highly concentrated bile. So as I mentioned, when there is low density, the gallbladder tries to concentrate the bile so that the pressure gradient is maintained. So when you see a white bile in a patient with upset jaundice, so you should understand why it is happening. And so that's why I included this slide. And we had a discussion about in the absence of a positive histology, should we undergo? So there is a residents can go through this. This is a consensus statement by the International Study Group of Pancreatic Surgery, and where they have highlighted where are scenarios where you can go ahead with PD even when there is positive. So I think some of the points we even discussed during the case discussion. Preoperative biliary drainage, I'm not going to go in depth as we discussed. These are the indications where there is no controversy. The bilirubin level, so never as a residents don't, whenever you're asked about the indication, don't start with a bilirubin level more than 15 because that's the most controversial indication. Always start with the indications which are the straightforward. And one point which I want to highlight is we always talk about the short-term outcomes, that is stenting increases the incidence of infection and the post-operative complications. There are some studies where they have analyzed the oncological outcomes. So patients with early ampullary tumors who underwent biliary drainage have adverse oncological outcome compared to those who did not undergo. This is actually, I'm talking about the early tumors where we expect to have a really good outcomes. Probably when you do stenting, so often you'll be cutting through the tumor, even though it is happening intraluminal, the process of cutting through the tumor initiates the tumor inflammation, and probably that facilitates the metastatic spread of the tumor cells. So never take this biliary drainage lightly. So don't do this without any indication. We should have indication to drain it because it can, in addition to the short-term problems, you can have the long-term complications also, especially the oncological outcomes. Then what about the extent of lymphadenectomy when you do as a part of pancreatic for periampullary tumors? I think whatever highlighted, so these are the lymph node stations which are included as a part of a standard lymphadenectomy. So the most important is, so you should be clear about this 14A, 14B. So these are the lymph nodes along the superior mesenteric artery, and if you can see there, only on the right side. So you, as a part of standard lymphadenectomy, you don't have to do a circumferential clearance of the superior mesenteric artery, but only on the right side. The 14A and B are the proximal and the distal lymph node stations. And the remaining are the 5, 6 is easy, 8, you all are aware, 12 is the HDL, 13 and 17 are the peripancreatic nodes. The 13 is the posterior and 17 is the anterior. So only these are the lymph nodes to be included as a part of standard lymphadenectomy. And the parietic node, that is 16B1, some studies mention that in ampullary tumors, you can, even if there are nodes are positive, you can go ahead with the pancreatic, but it's controversial. But as per the standard recommendation, the station 16 is considered metastatic, and only whatever lymph node stations highlighted in yellow, they are part of the standard lymphadenectomy, and this is as per the definition of the International Study Group of Pancreatic Surgery. So one controversy which is recently, I mean, you must have often seen in various meetings being discussed, is the role of neoadjuvant therapy in resectable pancreatic cancer. The one thing we should be clear is pancreatic cancer is never surgery alone. It's often a multi-modality therapy, and borderline resectable and locally advanced, no controversy, you need to give neoadjuvant. So more or less there is a consensus there. Now in resectable pancreatic cancer also, often you require therapy, systemic therapy, but whether it should be given neoadjuvant or adjuvant. So that's where the controversy is. So for the benefit of residents, what I thought is like take you through three key studies published recently and interpretation of those and what where we stand with respect to this subject. So this is the Preoperative trial, which most of you will be aware, the Dutch trial, where they had compared the neoadjuvant versus surgery followed by adjuvant. The important point to see is the neoadjuvant arm received gemcitabine, and during the second cycle, they also received radiotherapy, followed by surgery and 4 cycles adjuvant gemcitabine. But if in the surgery arm is surgery followed by 6 cycles. Now, the point to remember is this trial included both resectable and borderline resectable, and whatever the outcomes were published, and subsequently they have tried to do a subgroup analysis. So there is a bias with respect to inclusion criteria, and there are 2 publications. In the first publication, they have shown there is no difference in the outcomes. The subsequent publication in 2022, they have shown after 18 months, the survival curves started to separate, and probably the neoadjuvant therapy has a role in the long-term outcomes. So they have concluded that neoadjuvant therapy is beneficial in pancreatic cancer with respect to the long-term oncological outcomes. So this is the German trial, which was published last year. And if you see here, they have used the regimen which is used is gemcitabine and nab-paclitaxel. Only 2 cycles in the neoadjuvant setting and 6 cycles post-surgery compared to the typical arm where surgery followed by 6 cycles of gemcitabine and paclitaxel. Important points to note is 50% of the patients, this in final pathology, had a poor response or the progression. And if you see the resection rate, it's almost similar. In fact, 69% in the neoadjuvant and 78% in the surgery arm. So if you see here, the study was actually with started with the median survival of 55 months. But none of the arms actually reached the primary endpoint. So it's actually negative with respect to the primary endpoint. It's actually a negative study. But you get some good information with respect to what is the response rate with respect to this neoadjuvant therapy, and then how it influences the resectability rate. The more recent is the trial from Norway and Denmark. That's the NORPAC trial. Here they have used FOLFIRINOX, 4 cycles, surgery, then 8 cycles in the adjuvant setting, compared with surgery followed by initially gemcitabine, but after the Prodigy's study, then they have changed to FOLFIRINOX, 12 cycles. And here you see that 44% had a poor response and 50% had a moderate response. So the complete response is in a small proportion. And some of the proposed advantage of neoadjuvant is it allows you to complete the therapy compared to the patients who receive adjuvant, where a significant proportion do not complete their therapy. But there is no significant difference in both groups in completing the adjuvant therapy. And also there is no difference in the overall survival or progression-free survival. So the last, I thought I'll cover this. This is just to show that what is optimum neoadjuvant regime. We all talk about FOLFIRINOX, but SWOG study has shown that both are equivalent, both FOLFIRINOX and gemcitabine and nab-paclitaxel. So if you want to consider either the neoadjuvant or adjuvant setting, so both these are equivalent as per the current evidence. So these are the summary of the various neoadjuvant therapy trials. What I want you to focus is with respect to the dosing, the duration, the number of cycles which the patient receives, more importantly, the toxicity. You see the extent of toxicity reported in these trials. So as of now, you don't have actually a strong evidence supporting neoadjuvant therapy in a resectable pancreatic cancer. So that's more important. We are talking about resectable. The reason is compared to neoadjuvant therapy in maybe in esophagus or rectum, where you have a very good response in a significant proportion of the patients, but here you are going to have a relatively poor response rate with whatever regime available. So probably you still don't have a very good FOLFIRINOX. Definitely FOLFIRINOX and GEM-NAB are better than the previous regimes, but still compared to the solid tumors in maybe in the rectum and esophagus, still you don't have a good regimen which achieve a very good response. And also, you might lose patients purely because of complication related to neoadjuvant therapy. So which is actually a missed opportunity. Generally, we talk of neoadjuvant therapy selecting biologically good tumors so that we don't do unnecessary surgeries. But in resectable pancreatic cancer, what studies have shown is because of complications purely related to the neoadjuvant therapy, you could still lose patients. And so as of now, you don't have a strong evidence to support neoadjuvant therapy in resectable pancreatic cancer. I think that's a message, and you should be aware of all these recent trials and the key findings of those trials. So ideally speaking, so the future direction should be, we should look for who are the patient groups or what are the subtypes of tumors which will respond to neoadjuvant therapy. I think that should be the future studies, and also obviously the newer directed therapies rather than giving a toxic chemotherapy in an undirected way to all subset of patients. I think that does not seem to be the right approach. So the next concept which I'll briefly cover is the mesopancreas, because many times when you read about the surgical series, there will be total mesopancreas excision. So it's basically a vascular structure composed of fatty tissue, nerve plexus, lymph nodes, which are located in the retroperitoneal region. And the extent is from the pancreatic head to the superior mesentery and the celiac vessels, along with proximal jejunal mesentery. So this is what conventionally we talk about mesopancreas. That's basically the tissue from the pancreas head and uncinate to the celiac and the superior mesenteric vessels. And this is the radiological depiction of the mesopancreas. And why we talk about it? Because studies done almost 30, 40 years back have shown pancreatic cancer spread along the nerves. And these nerves are along the branches of the vessels which supply the head and uncinate process, namely these IPDAs and superior pancreatic arteries. And why this is considered as important? Because you don't have still level 1 evidence, but whatever evidence from the retrospective series have shown is mesopancreas excision reduces the local recurrence rate. This is uniformly proven. It reduces the local recurrence. But with respect to the overall survival, you still don't have strong evidence because, as we all know, we as a surgeon can focus only on local control. And the systemic recurrence has to be tackled by the chemotherapy. But mesopancreas excision does shown to reduce the local recurrence. And this is from the retrospective series. We still are awaiting there was the MAPLE trial, which is done in Japan, but the results are still not out, comparing mesopancreas versus the conventional pancreatic. And so this about whether we should be using this term mesopancreas, there is a controversy because we all know we use the mesentery, the term mesentery is used when it contains all the blood vessels which supply that organ. But we all know that all the blood vessels supplying the pancreas, head and uncinate are not through the mesopancreas. For example, GDA does not pass through that. So it does not contain all the blood vessels, and all the draining lymphatics also are not through the mesopancreas. You have lymphatics going along the hepatic artery. And so it does not actually fulfill all the criteria required for mesentery, but still this term is commonly used. And also we often use the term nerve plexus with respect to the pancreatic cancer. So what is nerve plexus? We all know nerve means is just a bundle of neurons with a connective tissue sheath, whereas nerve plexus includes nerves, blood vessels, and lymphatic vessels. So whenever we read these terms, we should understand what this term actually means. And that's why I've just mentioned those definitions. So it's nice to show in schematic diagrams, but during surgery, we need landmarks, how to identify this mesopancreas. So as I mentioned, the mesopancreas has 3 components. The one which is also called as, like, because commonly in literature, mesopancreas is used. The Japanese literature use the term pancreas head plexus. So it has 3 components. One is from the celiac trunk to the head and uncinate. The second component is from superior mesenteric artery to the head and uncinate. The third component is the proximal jejunal mesentery along the first jejunal artery. So all these 3 components form the mesopancreas. And so why the first jejunal artery territory is also included as a part of mesopancreas? Because when we talk about the ampullary tumors or the periampullary tumors, so the tumor region is supplied by these branches of IPDA. So this is just a schema, I mean, not actually a pancreatonectomy, but a different surgery. But for understanding purpose, I included this. So you can see these are the branches actually supply the ampullary region and also the head. And often the first jejunal artery arises along with these 2 branches. And that's why as a part of the total mesopancreas excision, the territory supplied by the first jejunal artery also should be included. So that's why we have the 3 components. And then there are various dissection lines which are described. I think it's good to understand about this because when we talk about this procedure, it has to be done in a standard way. So typically, I think often when we do this pancreatonectomy, we follow this dissection line 1, which means we go along the jejunum, then we reach the uncinate process of the pancreas, go close to the uncinate process, then take the branches of the inferior pancreatonal arteries. But then this increases the risk of R1 resection rate, especially in pancreatic cancers. So whenever we do pancreatonectomy for malignancy, it should be either dissection line 2 or 3. So these are the line with respect to the veins, and this with respect to the artery. So with respect to the vein, you have this, the first jejunal trunk also causes proximal duodenojejunal vein, or you have the branches from the pancreas draining into these veins. So we should go along this first jejunal trunk, taking off these pancreatonal veins with respect to the veins, and with respect to the artery, we should take the proximal jejunal mesentery along the first jejunal artery and then reach the SMA away from the uncinate process. So this is what we call as the beginning of the mesopancreas excision. And then once you reach the SMA, you go along it. That will take the pancreatic head plexus 2. And in the superior aspect, you take the pancreatic head plexus 1, that is from the celiac trunk. So this is what a typical mesopancreas excision means. I think once you understand this concept, that is fine. I think what you mean by mesopancreas and how you should do it. So probably I'll just skip that and because we are running short of time. So I'll just, highlight this. So this is just to schematically explain. So all the challenges you have during pancreatonectomy is due to this mesenteric rotation. So you see here, the first jejunal artery and its tributaries, they are on the infracoli compartment on the left side, whereas the head and uncinate process, they are on this side. So this rotation is maintained by this ligamental structures. This is not actually stick ligament, but you have this, the fibrotic structure. This is called the uncinate process ligament, which extends from the posterior surface of the uncinate process and attaches with the jejunal mesentery. So once you divide this, then the rotation is corrected. So you actually kind of derotate. You deliver the proximal jejunum into the supracolic compartment, and then you can see the uncinate process, the proximal jejunum, they all lie in the same plane. Otherwise, the jejunum will be lying here and the mesentery will be twisted. So this is the key part of the mesopancreas excision. You correct that embryological rotation so that you have the jejunal territory in the same plane as the uncinate process. So you go in this plane and then reach the superior mesenteric artery and go along the superior mesenteric artery. And then in the last part, you reach the celiac trunk. So that's the concept of mesopancreas excision. I think I'll, because there are some the surgical techniques which I'll skip. Two other technical aspects which as a students they should know is we all talked about the vascular anomaly, that is the replaced right hepatic artery. So whenever it is there, what are the options you have? Now, the best is when the replaced right hepatic artery is not involved, you preserve it. But when it is involved, so involvement of replaced right hepatic also, it's now included as a part of borderline resectable because the oncological outcomes are inferior in those patients. Why? Because they have the altered lymphatic drainage. The more lymphatic drainage happens into along the superior mesenteric artery, and some of these patients have higher incidence of even station 16 metastasis. Now, when it is involved, the options are either you sacrifice, or you can do a preoperative embolization, or you can transect and then reconsect. Now, is just ligating an option? It's not a preferred option, but it can be done selectively in the sense because if you are having a good collateral circulation in the hilum, and after dividing the artery, if the stump shows a good back bleeding, then most often you will escape without any major complication related to division of the replaced right hepatic artery, because this has been also shown in post-cholecystectomy bile duct injuries, where often there will be right hepatic artery injury, but many patients do not develop any significant hepatic necrosis. That's because you will have a good collateral circulation in the hepatic hilum. Between the left hepatic artery through the hilar collaterals, you will have supply to right. But however, this is not recommended. That's why one other option described is preoperatively embolize the replace right hepatic artery so that that collateral circulation in the hilum becomes well developed. But whenever feasible, you do the reconstruction when it has been sacrificed. But when it is uninvolved, then you can preserve it by following the artery-first approach. And the last technical point is when you do the vascular resection, the portal vein resection, the one point which is often described, that is when you are resecting the portal vein and the splenic vein is divided, whether you should reimplant or not. Most often, splenic vein reimplantation is not required because, as you can see in this, when the splenic vein is ligated, the drainage happens through this collaterals in the mesocolon close to splenic flexure or through the short gastrics into the left gastric vein. So, splenic vein need not be reimplanted if either you are preserving the inferior mesenteric vein or the left gastric vein or at least a middle colic vein. So if either of these three veins are preserved, then the reimplantation is not required. But there are instances where all these three veins will be ligated, and those are the circumstances where you need to reimplant. Otherwise, it is not required. I think probably with this I'll conclude, because the last aspect is about the minimal invasive, but I think we don't have time. Maybe we can just discuss this.
Thank you, Kalai sir, for such a wonderful talk. It was so much in detail with illustrations and with so much clarity. You were able to convey very complex anatomy. I'm sure a lot of students will be revisiting this talk of yours to probably understand better in depth the newer concepts that you spoke on. I invite IASO Secretary Dr. Rudra Acharya to kindly take our examiners through the Q&A which have come up in this webinar. I'll be sharing my screen and putting the questions up for everyone to see. Rudra sir, you're there?
Yeah.
Okay,
so thank you very much, Dr. Kalaisaran, Dr. Wariku, and Dr. Aksar. And both the examinees, I think they did a fantastic job. So periampullary tumors from esophagus and pancreas are the two most sorted after surgeries in surgical oncology and GI oncology. I think it was a very lucid presentation by Kalaisaran sirs, and both the examiners took the examinees through with tough questions, but both of them managed well. So now we come to the end of the talk almost, with few of the questions that have come up during the discussion. First question is upper GI endoscopy and biopsy indicated in a resectable tumor? How do you suspect pancreatitis-related benign tumors? I think anybody can take. I think this biopsy was taken by very well told by Dr. Kalaisaran sir. He can just take this question.
Yeah, I think that part we have actually mentioned. So when you see the lesion, you take biopsy, not for obviously when you are the positive diagnosis is good, but also look for alternate diagnosis. But if the biopsy comes negative, and if the other things are correlating with malignancy, your decision is not changed. So I think that we have covered. How to suspect pancreas-related benign tumors? Probably, I think he meant about the autoimmune pancreatitis or the IgG4-related pancreatitis, because that is something which can mimic a malignancy. But usually, you'll have the typical appearance, that the typical the sausage-shaped pancreas you will have. But however, the one of the feature which tells about this autoimmune pancreatitis are most of these patients, the bilirubin level will not be very high. What I meant is rarely it is more than 10. So there will be obstruction. Bilirubin level always will be somewhere around 5. And usually you the IgG4 levels will give us an idea. Serum IgG4 levels is a very useful investigation. And in case you still have a strong suspicion, then you can give a course of steroids. But again, it's a strong suspicion for autoimmune pancreatitis, not malignancy. Whenever there is suspicion of malignancy is high, you go with surgery. But the suspicion of malignancy is low and you are not able to establish diagnosis, you can give a course of steroids. And if there is improvement with respect to the parameters, then that actually indicates that it could be the autoimmune pancreatitis.
I think second question is the optimal timing of surgery following preoperative biliary drainage.
Usually, following preoperative biliary drainage, we tend to wait for 3 to 4 weeks for the liver function, synthetic functions of the liver to normalize, the bilirubin to normalize, as well as we'll have a look at the enzymes and the PT-INR levels. And the other thing to take into consideration would be the general condition and the nutrition of the patient. So if all these things are taken care of, I think 3 to 4 weeks should be a good enough.
Yeah, because most of the times we see during waiting time, the patients lose weight and they don't get optimized. So it is very important that although the bilirubin might go down, general nutritional status and optimization should be done before taking up for a Whipple's procedure, because it is going to cause a lot of surgical stress and complication and morbidities. So the taking time is not problem, but sometimes what happens is your bilirubin level falls to some point of level, and after that it becomes maybe flat. It doesn't fall more. So that is definitely a point of concern. All of us must know the chances of having stasis and failure. So we should always see that the bilirubin level comes to normal, and that is the best way you can intervene. Maybe 4 weeks or even more doesn't make any difference. Next question is process any comments, sir? Rasan, sir?
Regarding the flow section, sir?
For flat bilirubin level after some point of
so
going
generally,
down.
I think the optimal timing depends upon, as you rightly mentioned, about the indication. So like when you do for cholangitis, usually once the infection stabilizes and we take it. Regarding the bilirubin not coming down, so you will have many patients, like when they have very high bilirubin, so that is somewhere about 20. When you do stenting, one point you should remember is when the obstruction is relieved, then the bile starts again, the liver's hepatocyte starts producing the bile. The bile is more lithogenic when you actually release the obstruction. So the stent block is very common in the initial phase. So when you see a fall and then the bilirubin is getting stabilized, you should do an ultrasound, look for pneumobilia, rule out stent block. That's the first thing you should remember, because it often happens when there is a very high bilirubin, because immediately after drainage, the bile is lithogenic. So once you rule out the stent block, then you just, depending upon what was the primary indication for doing the biliary drainage, and then you decide about, because you should balance about waiting for the bilirubin to normalize versus the tumor spread, which is possible in the waiting period. So that's why the waiting period ranges from starting from 2 weeks to up to even 4 to 5 weeks.
Yeah. So thank you very much. That was wonderful. Next is each projection of non-regional nodes required if imaging is normal. Dr. Pawan can take this question.
Hi, sir. Good evening.
Yeah.
Yeah, I'll just put in two scenarios. If you have found an incidentally enlarged non-regional node either it can be because there's been a substantial amount of time which has lapsed between your imaging and your surgical planning. So that could be one option, one possibility, that there are new lesions which have cropped up in the wait period, or otherwise you've done your laparotomy, there's no systemic disease after quadrant to quadrant exploration, then you do your cauterization, come to a point where you have an non-regional nodes, either an inter-aortic cable or an para-aortic. If you have a frozen facility, it is always wiser to have an examination of this done before you embark on a major procedure. Having said that, if it is within the confines of inter-aortic cable or a limited para-aortic, you can still proceed with your Whipples, but have it in your mind, these are potentially M1, but with a limited disease. So basically, to prognosticate, yes, you need to substantiate yourself with a frozen section of all non-regional nodes.
So progen section is definitely helpful when you do Whipple's procedure, and if you find non-regional nodes, then it should definitely be sent for progen section. Next question is how to manage.
Just to add, sir, that basically,
please.
Dr. Pavan mentioned, so because there are still some centers in periampullary tumors with 16B1, they go ahead with surgery, even if it is positive.
Correct.
So a frozen section is actually indicated if it is going to change your management. If the policy is, if it comes positive that I'm not going ahead with the resection, so then frozen section is mandatory. But the centers which go ahead with, so probably you do go ahead with a dissection, and there the frozen section may not be a really essential
useful
step.
Yeah. So next question is how to manage post-operative intraluminal PJ bleed. Wonderful question. I think Dr. Kalayasaran or Pavan, anybody can take, or both can take.
So
the two aspects of it. Yeah, Dr. Kalai.
Yeah, please go ahead, Dr. Pavan.
So there are two aspects to it. Either it can be an post-operative intraluminal or post-operative pancreatic hemorrhage which has occurred within 48 hours or beyond 48 hours. If it is within 48 hours, you very well know that it could be one of the potential reasons of your GJ site bleed. And if you have facilities, then you can have an endoscopy done and you can clip the GJ site bleed. If it is beyond 48 hours, you do a conventional you do a CT angiograph, you see a blush in the GDA. It is always wiser to have an GDA embolized. And prior to this, you'll have a small subtle hints of a sentinel bleed in your drain, where day 3, day 4, you notice a bit of a change in the character of the drain, which is a kind of a sentinel warning sign that there could be a potential GDA aneurysm imminent for an post-operative pancreatic hemorrhage. So if you have a good intervention facilities, you can have an GDA embolized and have a control of the source.
Yeah.
I'd like to say that the question was put a little bit differently. The bleed is intraluminal from the pancreatojejunostomy anastomotic site. So all those menus would help us if it was an extraluminal bleed. For an intraluminal bleed from the pancreatojejunostomy site, usually happens at the anastomotic site. So the menus would be a little bit different.
Yeah, actually, here the management depends upon the timing. So early post-operative, that is happening in first 24 to 48 hours. So usually it comes from the pancreatic cut surface. Now, most of this settles with conservative management. But if you are forced to go in, like it is, you have given FFPs, you are given Tranex, but still not settling down, you are forced to go in, then the option is, because you don't want to disrupt the PJ site, you actually make a enterotomy opposite to the your PJ. Then from inside the lumen, you visualize. And if you can identify the bleeder, then you can take a suture. Often this is actually in one, once we have done that, but that was actually intraoperatively. So after doing, we saw the PJ limb getting filled up. with blood. And then we actually gave an enterotomy opposite to the PGA, identified it, and then taken a suture. So that is a maneuver which will be useful in the early phase. Obviously, in the late, as whatever Dr. Pavan has mentioned. So because sometimes GDS pseudoaneurysm will manifest as intraluminal, especially because often it is due to the PGA disruption, and the pseudoaneurysm will bleed into the lumen. So there, obviously, the management is like any GDS pseudoaneurysm.
Yeah. So again, the best management for the intraluminal PGA bleed would be to prevent it in the first place. And for that, you need a meticulous handling of the pancreatic cut end. And most of the times we try to do it with a cold knife cut. And all the bleeders, we take Prolene sutures, and all this, even the smallest of the bleeders, should be stopped preoperatively and after optimizing the blood pressures. So you should be checking whether there's any bleeding from the cut surface.
Yeah. Is there any role of embolization?
So most of the times, the intraluminal bleeds will be associated with some amount of bleed because of pancreatic leakage, and there could be associated aneurysm. So there definitely we can think about embolization.
Yeah.
If in the late setting, it will be embolization useful, but in the early, embolization is not useful.
So mostly, as my teachers used to say, when you see the drain that you have put at the pancreatic stump, first it becomes white, then it becomes gray, then it becomes red. So when it is red, that is the what is called as sentinel bleed. And once the sentinel bleed is there, then you suspect whether it is intraluminal or extraluminal, and accordingly you decide. So it is very important that all the pancreatic surgeons, it is not only important to do the pancreatic surgery, but handling complications, because as you know, to the extent today, even 25 to 30% of morbidity to have the complications is known, and to handle complication makes a better pancreatic surgeon. Next question is how to manage pancreatic sufficiency or insufficiency in follow-up. Dr. Pavan?
One of the significant clinical finding of pancreatic insufficiency in the follow-up is failure to thrive or failure to gain weight. And often patients come back with, passing bulky fatty stools which keep floating. Best way is to substitute pancreatic enzyme replacements, either 25,000 units or 10,000 units, but they come at a price. I know that cost is bit of the commerce to it is bit on a higher side. So start off with the 10,000 units of pancreatic enzyme replacement. BD, if it doesn't, then 25, you can step it up to 25,000 BD doses, either Creon or Pancreoflat.
Okay. So
and that's for,
that
for life.
Yeah, that ends today's questions. Just one question for benefit of the students. How do you, on imaging, define the unresectability to borderline resectability to resectability with respect to the vessels? Dr. Wariku?
Yeah, so resectables, we'll define it. If you are talking about a head malignancy, we'll be defining it with relation to the veins as well as the arteries. So basically, if the arteries are involved, it becomes unresectable, even though technically there are quite a few centers where we are practicing arterial resections and arterial divestments. But the veins, the basic philosophy is that if the vein is resectable, then it is borderline. If the vein is involved and it is resectable, then it's a borderline resectable. And
so, Dr. Kalarasan, any comments on this?
And if the vessels are free at the outset, it's a resectable tumor.
Yeah.
I think it's nice to summarize. Basically, the reconstructable venous involvement becomes borderline resectable.
Very nice.
When you can't reconstruct, or the arteries other than the hepatic artery. So it becomes unresectable.
I think color results are shown in the presentation. Very nice of describing the mesopancreas. Previously, nobody was giving so much importance to mesopancreas. Now the whole dissection is rotates around mesopancreas and the nerve plexus. So thank you very much for today's session. I thank all the examiners and examinees for doing nice job. Back to Srijan, please.
Thank you, sir. With this, we'll conclude our webinar today. Thank you to Dr. Pawan Sukur for creating two beautiful case capsules. It's a shame we could only complete one. I hope we continue this session someday else and finish the other part of the case capsule as well. Thank you, Dr. Vikas Variku, for being a true examiner and letting the students know how an exam actually goes. I think his questions were exactly in line of how examinations go, at least in surgical oncology. And thank you, Dr. Kalirasan sir, for the wonderful talk and all his illustrations that he showed. Thank you, Dr. Rudra sir, for the excellent moderation of Q&A and supporting us through IASO academics to continue these master classes. With this, we'll conclude today's webinar. We'll meet again in a fortnight's time, another Tuesday at 7 p.m. Another masterclass. Thank you so much, everyone. Have a good evening.
Thank you, sir.
And I request all the students to register for the NatCon Bangalore, and we will all be meeting there for our next annual conference. Thank you very much.
Thanks a lot.
Thank you.
Thank you.
Good night.
Good night. Good night.
Good night.
Thank you.